So in today's video of the HRCT temporal bone, I'll be talking about the much more detailed version of the anatomy. Also at the same time, I'll be talking about the pathology of the different anatomical sections which you see in the HRCT temporal bone. As you can see today in this video, I'll be talking about the both the scans at the same time. That's the axial and the coronal. So if you can see on the screens this side, you can see it's in the axial scan, and on this side you can see whatever section you see is the coronal scan. So whatever anatomy I'll be talking about on the axial, at the same time with this navigation cursor you can see here, I'll be showing you the 3D anatomy on the coronal section as well. So basically we get a rough 360-degree view of the anatomy and the direction and the layout of the anatomical structures at the same time if viewed on the axial as well as the coronal. So whenever you ordering a CT scan, always make sure you order it around 0.5 to 1 mm thickness, and you get it for both the axial and the coronal. The sagittal sections are also important. If at all possible, I'll be covering a different video especially showing the sagittal section itself, but today you're gonna see the axial and the coronal at the same time. So in the previous video of the HRCT temporal bone which I had uploaded, I was talking about the basic anatomy from a beginner's point of view, but today in this video I'll be talking much more in advanced and also with the related pathology as well. So starting with the HRCT scan on the axial side, as you can see, I'm going from inferior to superior. Once I finish off from going inferior to superior, I'll be talking and I'll be showing you how to identify and start reading a scan from the superior to the inferior as well, because both these directions are really important. Some prefer from going up to down, some prefer from going below to up. Okay, so I'm going to start the video from going inferior to the superior aspect. Now let's begin. If you remember in the last video, I had talked about the basic 3-point identification system. That is basically what you can see right now. These are the 3 points of identification if you're going from inferior to superior. Now the very first inferior, that's the posterior point being the mastoid tip, then the more medial being the styloid process, and the one above, which is the anterior part, is the ramus of the mandible with its 2 heads. The posterior one being the condylar process, that's the head of the mandible, and the one which is more anterior is the coronoid process. Okay, now I'm going to show you these 3 structures on axial and coronal at the same time. So if you can see, this is my navigation cursor. I have kept it on the mastoid tip, and if you can see on the coronal section, you can see actually that the navigation cursor is at the tip of the mastoid. So this is the mastoid tip. You can confirm that at the coronal section. And as if we go up, you can see if I'm going from inferior to superior, you can see the axial is trying to show me the mastoid air cells, and on the coronal section you can see the yellow line which is going above. So that's showing me the plane I'm in right now on the coronal. So you can see all the mastoid air cells on both the sections at the same time, and that is how you study the nature of it. Okay, so I'm going back inferior and I'm going to show you the second point, which is the styloid process. So this was a styloid process. Now we all know the styloid process comes from posterior to anterior and from lateral to medial. So I'm going to show you, keep my navigation cursor on the styloid process right here, and on the coronal section you can see that's the styloid process coming from lateral to medial and from posterior to the anterior. So the styloid process is directed anterior medially, that's for sure, and we're going to go more inferior so that the mastoid tip disappears, and still the very tip of the styloid process is quite visible right now to us. So that's still going below further. You can see the mastoid tip over here. Now I'm going to keep my navigation cursor over here. You can actually see on the coronal section how the styloid process is coming into the picture right now. You can see the entire structure and the course of the styloid process, and as we keep on coming again superior, you can see if I just keep on my cursor, You can see how the styloid process is coming into picture. So this is how you basically compare the styloid process entire length on both the sections. Now, why is this so important? Now you can see this is the mastoid tip. So this was the mastoid tip, and this is the styloid process, the styloid bone. So basically, styloid bone has two parts: the extratemporal part and the intratemporal part. The intratemporal part, which lies within the temporal bone, which I'll be talking about later, but the extratemporal part, which you can see hanging over here down below, which goes anterior medially. So between these two, you're going to have the stylomastoid foramen. So when I'll be talking about the entire facial nerve canal, I'll be showing you the entire anatomy of the facial canal, that's the fallopian canal, and the facial nerve as well. And I'll be showing you how it exits through this stylomastoid foramen right here. So this is kind of important to know the anatomy of the styloid as well. So coming back to the third point, which is over here, if I bring my navigation cursor right here, that's basically the ramus of mandible. So see, my cursor is exactly pointing here on the axial scan, and the same thing on the coronal scan. I'm at this level of the axial cut. So you can see this is basically the ramus of mandible, which we all know the ramus of mandible divides into two processes. The anterior one is the coronoid process, and the more posterior one is the condylar process, basically, which forms the head of the mandible, which fits into the mandibular fossa of the temporomandibular joint. Now, that mandibular fossa is also called as sometimes the glenoid fossa. The other term for glenoid fossa we see in the shoulder joint as well, but this is also called as the glenoid fossa, the mandibular fossa. So if I keep going up, you can see this ramus is disappearing right now, because now we all have is the head of the mandible. As we keep on going up, you can see on the coronal section the yellow line keeps going up, and now here comes the mandibular fossa, and that's the actual TM joint over here. Okay, so this is basically the TM joint. Now, why is this more important? Why am I teaching you the anatomy of the TM joint over here? Now, because in certain cases of mastectomy, when a person or surgeon is drilling, and if you're drilling the if you're drilling the anterior EAC wall, that's the anterior bony wall of the external auditory canal, which you can see over here right now. That's so if I keep my navigation cursor over here, that's basically the bony external auditory canal, and that's the anterior wall of the EAC. And if you drill that during basically a canaloplasty or a thinning of, if you have a narrow EAC and if you try to drill that wall, you can expect if you drill that too much, the joint is going to prolapse behind and going to come back into the EAC, and that's going to be a problem to the patient post-operatively. So that is the clinical significance of that area, and that is why you should know that the TM joint, that is the mandibular fossa, is in very close relation anterior to the external auditory canal opening, that's the anterior tympanic wall. Okay, so these are the 3 points which you should be knowing to start your HRCT temporal bone. So I'm coming back very inferiorly again. So 1, 2 and 3, these 3 points are done for now. And later on, the fourth point of importance will be the external auditory canal. So as you keep going up, you're going to see the external auditory canal, and if I keep my navigation cursor on the axial scan EAC, you're going to see this is the external auditory canal coming into the picture. So on CT scan, anything which is bone is going to appear as white. Anything which is a diseased soft tissue or a liquid is going to be seen as a hyperdense soft tissue grayish material on the CT scan. And air is always jet black. So wherever you see jet black, it is air. Okay, so you keep that basic in mind. So this is the external auditory canal, which is consisting of air. Basically it's all air. Okay, so that is why it's jet black. So that is why if there is any prolapse or any dehiscence in the dura or the tegment mastoidium or tegment tympani, or there is any erosion, or post-operatively there could be a prolapse of the brain tissue or meningoencephalocele into the external auditory canal, and you can have a soft tissue over here in connection to the dura outside, which I'll be showing you in the pathology later on. So that is how you can identify that there is something wrong going in the external auditory canal. So this is the external auditory canal. As I keep going up, so I'm going to keep on going up till I reach a point where the external auditory canal is in complete picture right now. So if I turn my navigation cursor over here, you can see this is the external auditory canal in its entire length. That's the external auditory canal in its entire length. And if I keep going up, at the very end of it, you can see a faint shadow of the tympanic membrane. If I keep my navigation cursor on the tympanic membrane, on the coronal section, you can actually see the tympanic membrane attached to the ossicles right there. You can see that's the tympanic membrane right there, and these are the ossicles. But you cannot see the ossicles yet on the axial, but you can have a glimpse of the ossicles on the coronal section, which I'll be discussing why. So basically, you have to remember that these are the two parts of the EAC. So if at all, the outer part is cartilaginous EAC and the inner part is bony EAC. You can see the bone over here, that's the anterior wall, and here that's the posterior wall. So on the axial scan, what you can see over here is the anterior part, what you see over here is the posterior part, and on the coronal scan, what you see above here is the roof, or you can see the superior wall, and here is the floor or the inferior wall. That you have to be keeping in mind. So fourth point you have to identify is the external auditory canal and the tympanic membrane right there, and the importance of the EAC. So sometimes the EAC could be narrow, and sometimes the EAC, the bony, now have a look on the bony EAC over here. You cannot see any bony dehiscence as such. The TM joint is normal. The posterior canal wall is also pretty much intact. This is the mastoid air system. You gotta drill the area from here, you gotta enter the area from here, because in case of MRM, this is the auricle. You can see you have to retract it and you gotta drill from here. But this is way too inferior. You're gonna still go more superior, and I can show you the exact area where you can drill from the cortical mastoid, the cortex of the mastoid bone. So we're gonna keep going up. Now if you remember the last time, I told you, once you see the EAC and once you see the tympanic membrane, the two most important structures which you come across are the IGV and the internal carotid artery right there. So if I can see, if I'm going below, and now this is the exact point where I could see the tympanic membrane, and there you can see two finger-like projections right there. That is the internal carotid artery, and that's the internal jugular vein. That's the jugular fossa. That's the jugular bulb, basically, not the fossa. That's the jugular bulb, and that's the internal jugular vein, IGV over here, and that's the ICA. And somewhere here you can see the sigmoid sinus much more clearly. As we go on a little bit superior, you can see the actual sigmoid sinus. Okay. So one more point in the EAC of the bony part, if the patient is having a condition called as exostosis, you're going to see complete narrowing of the EAC in the bony part and huge hyper intense signals you can see off the bone. It's basically a bony growth, which you can see like bulbous form over here in cases of exostosis, completely occluding the EAC of the patient. You can see some dehiscence over here sometimes in cases of erosions or infections, or basically malignant otitis externa, recurrent infections. You can have dehiscence over here in cases of skull base osteomyelitis, which take origin from the external auditory canal. So basically, if you see on the coronal section, I have to show you because I came across a case of skull base osteomyelitis. Now basically, if you're seeing on a coronal scan, now the external auditory canal, the bony one, the cartilaginous one, the floor of the EAC, they have got vertical fissures of Santorini, which act as a source to spread the infection from the external auditory canal skin into the IGV, the posterior mastoid, and the skull base behind. So that is the usual route taken by the infection in cases of skull base osteomyelitis. So you can see a lot of dehiscence in the external auditory canal bone if at all there is a severe infection. Okay, so coming back to these two major structures, that is the internal carotid artery and the IJV right here. So what you can see over here is the IJV and the ICA. Now, I'm keeping my navigation cursor first on the internal carotid artery. Now, this is very, very, very important. Now, in my previous videos, I have explained the entire course of the internal carotid artery, right from its origin in the neck, from the aorta, basically going up to the termination as the ACA and the MCA. So I'll post a link of that video. You can go and have a look of the entire course of the carotid. But few people know and are experts in the course of the ICA in the temporal bone. So today in this video, I'm going to show you the course of the ICA in the temporal bone, the petrous part of the temporal bone, both on the axial and the coronal scams. You will have a better understanding of the course of the ICA. So I'm just going to shift the scan to this side to have a better picture here right now, and this a little bit on this side. Okay, so concentrating on the ICA. Now if I keep on going below, now that's the origin of the carotid. Now if I keep my cursor over here, you can actually see that this is the origin of the internal carotid artery on the vertical. That's the coronal section. So if I'm going up, you can see that projection becomes more clear. And now see, as soon as the carotid artery enters from the neck, that is the parapharyngeal part of the carotid artery in the neck, it enters along with the IJV in the carotid sheath, and it enters through the carotid canal at the base of skull and forms a short vertical part of the vertical segment before it forms the first genu and turns horizontally, and again forms the second genu and turns vertically up to form a short vertical segment before it exits the foramen lacerum. So what I'm showing you right now, if I'm going below, you can see a faint shadow of the ICA appearing right now. This is basically the part of the ICA which has just entered the carotid canal at the base of skull. And this is a short vertical. See, as we are going above, and I'm keeping my navigation cursor over here, you can see it's still the vertical segment of the carotid. Now, this is a short vertical segment. The moment it enters the skull base through the carotid canal, and after a while, it's going to take a turn, which we call as a first genu, and take a horizontal course in the petrous part of the temporal bone. So if I keep on going up, you can have a close look. I'm going up. Now you can see that's the genu over there. And if I focus the cursor over here, you can still see the oval shaped carotid artery right here. This is just before the turn. So if I keep my navigation cursor over here on the coronal scan, you can actually see how the carotid artery is turning. Now keep your attention on the coronal section. You can see this is still the short vertical segment. Now as I'm going up, you can see this is the first genu. That's the turn of the carotid, and that is the turn of the carotid. You can see that bony covering over here. See my cursor, that's the bony covering at the turn, and you can see a bony covering at this turn. This is the projection which you can see in the inferior part of the middle ear near the hypotympanum. So this is that bulge which you can see in the middle ear cavity towards the inferior aspect near the ischion tube opening. So the ischion tube opening is kind of superior, then comes the internal carotid artery bulge, and below that will be the IJV, that's the jugular bulb. So this is that bulge which you can see in the middle ear wall. So if I'm putting my cursor and you can see the actual turn. Now focus on the coronal section. You can see the actual turn of the carotid. Now this is basically the horizontal segment of the carotid in the petrous part of the temporal bone. And you can see if I keep on going up, you can see still it's the horizontal segment. If I keep my cursor over here, it's still the horizontal segment, and then it's going to have one more turn up, and then it's going to ascend vertically for a short segment before it exits the foramen lacerum. Now if you see the base of skull, you can see the foramen lacerum to be somewhere over here. Now if I keep my cursor over here, and you can see on the coronal section, this is the foramen lacerum area, and if I keep on going up, you can still see the horizontal segment, and now all of a sudden you'll see that the horizontal segment disappears. See, the horizontal segment disappeared. If I go back, you can see that's the horizontal segment. If I go up, you can see the horizontal segment to be disappearing, and if I keep my cursor over here and you can compare the coronal section, this is the segment of the carotid which has now left the foramen lacerum and has entered the sphenoid bone along the clivus. You can see that's the clival bone right there, and that's the carotid bulge you can see on the lateral aspect of the clivus. So this becomes the paraclival carotid, and it still ascends up. So if I'm going up, you can still see on the coronal as well, it's still going up, it's still going up. This is still the paraclival carotid, and now you can see it's going to turn into a cavernous carotid. If I keep on going up, you can see it's going to turn into cavernous carotid. So this is a cavernous carotid, and it eventually ascends up to become the paraclinoidal, and then the cisternal part, it becomes intracranial, cisternal, and it gives off the ophthalmic artery and the superior hypophyseal artery, and then it further terminates into the ACA and the MCA. So basically this is a course of the actual internal carotid artery seen on the temporal bone. So coming back below again to our basic point, you can see that this was the mastoid tip, and we were at the external auditory canal, that's the tympanic membrane, and that's the ICA. So if I keep my navigation cursor here, you can see on both the scans, that was how you check on the internal carotid artery right there. Now the next structure which is in close relation to the internal carotid artery is basically the IJV, and I hope you all understood the ICA course. Now keeping focus on the IJV, if I'm going to take my navigation cursor on the IJV over here, that's the IJV. So if I'm going from below, to above, see that was the mastoid tip. Going above, you can see the EAC, and that's the tympanic membrane, and that's the jugular vein. So that's the jugular bulb. Now the clinical importance of this jugular bulb is that now this basically, in this patient, you can see a thick bone which is covering the jugular bulb. That's the jugular vein, the fossa. Basically that's the thick bone. So if at all in a CT scan you see that this bone is dehiscent or this bone is very much thinned out, sometimes what happens, a diverticulum comes outside. Similarly, you can see this is the carotid artery, and that's the bony covering. Sometimes this carotid artery bony covering could be dehiscent, and a diverticulum of the artery can be coming out. So basically a part of the artery can prolapse into the middle ear fossa or the middle ear cavity and give a pulsation outside behind the tympanic membrane. So if a surgeon directly goes inside and opens up and thinks that it is a soft tissue and just tries to remove that, the surgeon is basically unknowingly hampering the patient's ICA. So always get an MR angio or basically a MR scan to know for sure that whether it is carotid or not, or basically any other tumor. The same thing happens in cases of the jugular bulb dehiscence. So this bone could be dehiscent, and the content of the jugular bulb, that's the jugular vein, could be protruding inside and can cause massive hemorrhage inside. So you got to have this basically is a vein, so you got to have a venogram ready if at all you see on the CT scan that this bone is dehiscent and the soft tissue is coming out, prolapsing outside behind the tympanic membrane. You could always get an MR venogram done and study the course of the IJV. So coming back, so if you can just follow the IJV over here on the coronal scan as well, you can see that's the IJV. So there's a basic mnemonic which you can remember. So as long as you see the cochlea on the scan, you should be seeing the carotid, and as long as you're seeing the vestibule, you should be seeing the IJV. Okay, that's a jugular bulb. So if I can see on the coronal, now this is basically what this is what, now I can just show you the cochlea. So this is a basal turn of the cochlea, which I'll explain later on. So what you can see, this is a basal turn of the cochlea, and if I keep my cursor over here, you can see this is the carotid artery. On the axial, I'm pointing out this is a carotid artery, right? And on the coronal, this is the carotid artery. But what you can see, only the cochlea is under visualization. This is the cochlea, basal turn, the mid turn, and you can see this is the this is the entire cochlea. You can see the basal turn, the mid turn, and the apical turn. And this structure which you see right now is the carotid artery and not the IJV. So if you have to visualize the IJV, which is right here, and if I keep on going up over here, you got to see the vestibule, or at least the semicircular canals right there. So if you see vestibule, it has to be the jugular bulb. If you see the carotid, it has to be the cochlea up there in view. So that is basically a mnemonic for you to understand if you're just given a random spotter to identify. Okay, so this is all about the IJV and so far the dehiscence inside. And there's one more structure which you can see over here is the sigmoid sinus over here. Okay, so that's the sigmoid sinus. This entire structure is sigmoid sinus. So let me go from very inferior to superior. I guess you should be having much more clear idea if I go from the very below to the above. So that's the mastoid tip coming into picture right now, the entire trabecular meshwork, and then you can start seeing the appearance of the sinus area. Now this bulge you can see over here, that's the basic sigmoid sinus, which is inferior and the most posterior structure from all. So this is basically the sigmoid sinus. You can keep following that on the coronal section as well. You can see that's the sigmoid sinus on the coronal sections. So what happens, so what you do is basically see, that's the EAC. You're going to retract the ear like this, and you're going to start drilling from here. So that's basically the antrum area. Now let me show you the antrum just for your knowledge. You can see that's the antrum over here. That's the epitympanum. That's the ice cream cone appearance, which I'll be talking about in detail after some time. But this is the antrum bone. If I can just show you, that's the antrum bone on the coronal. That's the antrum. And so when you come from here, you can see on the coronal scan, when you drill from here, this is a periantral air cell. You gotta get rid of that. And then when you enter the antral air cell, the very structure which you can see over here is a semicircular canal, which is in direct concern, which is the lateral semicircular canal, the bulge of the lateral semicircular canal, which you can see right there. So basically this is a sigmoid sinus. Now the clinical significance of this sigmoid sinus is that it could be anterior placed sigmoid sinus. Now there are 4 categories of sigmoid sinus. Is basically what happens is that you got to find the posterior semicircular canal. See, you can see the posterior semicircular canal right here. So what you can do is that you can draw a straight line from the posterior semicircular canal, both ends of the posterior semicircular canal. You draw a straight line like this, make it pass through like this, like a plane. So if your sigmoid sinus, the very prominent part of the sigmoid sinus is medial, or so medial becomes, this is medial and this is lateral. So if it is medial or posterior to that line, it becomes type 1. So the most prominent part of the sigmoid sinus, if you draw a line like this, and if that prominent part is medial, or you can say posterior to that line, it becomes type 1. The second line is that you draw a straight line through the ice cream cone appearance of the ossicles like this. You draw a straight line like this, and so this becomes line 2, and the previous one which I showed becomes the line 1. This is line 1 like this, and then this is line 2 like this. So between the line 1 and line 2, if the sigmoid sinus most prominent part lies medial or posterior to the area between the line 1 and the line 2, it is basically type 2 sigmoid sinus. So, and type 3 and type 4, there's one more line which is somewhere placed from here to here. So if it is placed between the line 2 and the line 3, it is a type 3 sigmoid sinus, and then type 4 beyond. So type 1 and type 2 are easy for surgeons, they are easily visualized, but then type 3 and type 4 are dangerous while performing the surgery. So if it is anteriorly placed, you gotta have a very careful procedure done during the surgery, because if it is too much anteriorly placed, you have a chance of damaging the sigmoid sinus, and you can have a lot of bleeding inside. So that was about the sigmoid sinus. So okay, so going from below above, we had the three major vascular structures. One is the internal carotid artery, which is this one, the entire course which we just saw, and the dehiscence of the ICA in the middle ear. The second one is the IJV, that's the jugular bulb, and the third one being the sigmoid sinus. So these are the three vascular structures which we saw from below to above, and that was the EAC and the tympanic membrane. Now the most important thing, now coming on to the internal ear, now I'm directly going to go and teach the internal ear structure. So remember the sequence. First, from inferior to superior, you will see the mastoid tip, the styloid process, and the ramus of mandible dividing into the coronoid anteriorly and the condylar posteriorly, eventually forming the head of the mandible. That's the mandibular fossa and the TM joint. Then as you keep on coming superiorly, you're going to see the external auditory canal and the tympanic membrane right there. The moment you see the tympanic membrane, you're going to see the IJV, that's the jugular bulb, and the carotid artery, and the sigmoid sinus. Okay, we all read that. Now coming on to the internal anatomy of the anatomy of the internal ear, that's the labyrinth. Now keeping the internal carotid artery as the landmark, always keep the ICA, that's the internal carotid artery, as the landmark. As you keep going above, just remember you gotta keep going above, right? So as you keep going above, you're gonna see that's the ICA, and shortly you're gonna see a bony projection coming on from the ICA. Okay, that's the bony projection you can see coming from the ICA. Still, I'm gonna keep going up. You can still see the projection becoming more bright. That's the bony projection coming from the ICA bone, and you can see it becomes more prominent. And then in the very same bone, you're gonna see something shadow over here, and that is basically nothing but the basal turn of the cochlea. So this is how you start seeing the internal ear, that's the labyrinth structure, anatomy of it, as you keep going from inferior to superior. So you got to focus your attention on the ICA course. The moment it becomes horizontal, you can see a bony projection right here, which is called as the promontory, which we all know is the bulge of the basal turn of the cochlea in the middle ear. So that's the basal turn of the cochlea inside, and that's the promontory bone, which you can see head on through the tympanic membrane during your T-plasty surgeries. That's the promontory basically. And we all know the second structure, which is just lying posterior to the promontory, is the round window. So you can see something over here, the blackish stratum over here, that is basically the round window, which eventually connects to the basal turn of the cochlea. So if I keep on going up, you can see the basal turn of cochlea becoming more prominent, and you can see a parrot beak, or you can see basically an eagle appearance. So basically, if you imagine this becomes the beak of an eagle, and this beak, which is exactly looks like the beak of an eagle, is nothing but the round window niche, and becomes more prominent as we keep going up. And you can see that's the basal turn of the cochlea, which is opening up, and this is basically nothing but the round window. Now in cases of cochlear implantation, most of the surgeons use this as a route of entry to introduce the electrode of the cochlear implant inside. So they introduce the electrode through the round window. So depending on the CT scan, you got to study how much is the round window niche over here. Now niche is basically a bony projection from a flat surface, and what you can see over here is the round window over here. That's basically where the basal turn of cochlea opens up, and this is a round window, and you can see a faint shadow of bone here as well. So this is basically round window membrane. This is a bone which is a niche that covers the round window, and you can see, I can just zoom this for you. You can see a very faint shadow over here. That is basically not bone, but that is basically a round window membrane, you can see right there. So the clinical significance of this round window is that whenever you're performing a tympanoplasty, you can see you become very happy, right, that you saw the ossicle. Now let's check for the ossicular in the mobility. So you take your ball probe and you touch the handle of malleus and tap on it. You can see the IS joint moving as well. And then what you see for is the round window reflex. So what is basically happening inside is that when you tap on the malleus, the physical vibrations move on to the incrumalleolar joint, onto the incus, and from the incus to the stapes, and from the stapes to the stapes footplate. From the footplate, now we all know that the stapes footplate corresponds to the oval window through a thin membrane, right? And there is perilymph inside. So all the vibrations are transmitted through that perilymph endolymph system, and eventually through the vestibule it enters. So basically the oval window opens in the vestibule, right? So through the vestibule it connects the cochlea. Through the endolymph and perilymph, the transmissions are dissipated, and they appear to be moving through the round window. So basically round window acts as a release valve for all the energy which is being dissipated in the cochlea, the fluid vibrations. So it basically acts as a release valve. So whenever you touch the malleus, you can see positive round window reflex. That means the ossicular chain is intact. So this is basically that round window. You can see the round window membrane and the niche over there. So what we saw so far is a basal turn of cochlear, right? And then this is a round window. That is the round window membrane right there. That's the niche, which is a bony covering of the round window. So as we keep on going above, now the moment you saw the cochlea, that's the basal turn of the cochlea, you can see something over here, which is like a tube-like structure going inside. You can see here, and you can see eventually it is connecting to the basal turn of the cochlea right there. You can see a very, very faint crack-like, fracture-like segment over here. That is basically nothing but the cochlear aqueduct. Okay, so that is basically the cochlear aqueduct. Now, coming on to the coronal section, if I keep my navigation over here on the promontory, you can actually see that this is a tympanic membrane, and that's the bulge of the promontory, and that's the basal turn of the cochlea right there. As I keep going up, you can keep going up. This is a basal turn of the cochlea, and you can see the actual 3D orientation of the basal turn of the cochlea becoming the middle turn and then the apical turn, which I'll come back to it again. So if I keep going above, you can see now on the coronal, on the axial section, you can see the vestibule over here and the cochlea over here. And you can see a glimpse of the internal auditory canal right here. But that is too much for you right now. Let me come back a step back. So coming back to where just the cochlea was visible. Okay, let me just show you the place where just the cochlea was visible. So that is the cochlea, right? The basal turn of cochlea. Now look, pay attention on the coronal section. You can see this is a basal turn. This is a basal turn. That's the basal turn of the cochlea on the coronal section. See the blue and the yellow line where they're corresponding is the basal turn of the cochlea. Now you can see something, you can see over here, that's the interscalar septum. So basically there's a basal turn, there's a middle turn, and there's an apical turn. Okay, all these turns are distinguished from the interscalar septum. So prominently the basal turn and the middle turn, there is a partition in between, which you can see right here. You can see right here, that's the interscalar septum. Now you can see that on the axial section as well. That's the basal turn. See, that's the basal turn on the axial section. And now you can see the whitish bone here. That is the interscalar septum, this is a middle turn, and this is the apical turn. And I'm going to show you the same turns on the coronal scan. You can see that's the basal turn, that's the middle turn, and that's the apical turn right there. So this is how the cochlea is formed. Now this patient has a normal cochlea. Now the clinical significance is that in a lot of patients who are young, 3 years, 5 years, or like very young, they have congenital deafness. A lot of cochlear anatomic deformities are there. Michel's deformity, Mondini's deformity, then IP1, IP2, IP3. IP stands for incomplete partition deformity. There are 3 types. I'll show you how they are and how they appear a bit later on. But let me show you the basic anatomy of the cochlea first. And then I'll come on to the vestibule. And then later on, I'll come on to the semicircular canals. So first is the cochlea. We are going very systematically. So I showed you all the 3 turns of the cochlea very easily on the axial and the coronal orientation as well. So as we keep going higher on the axial scan, you can see a cauliflower like appearance of the cochlea right there, like this. See, I'm gonna go below. That was the ICA, that was the promontory, round window, the niche. That's the basal turn of the cochlea. As we keep going up, the basal turn becomes more prominent, and then that's the round window niche in connection with the basal turn of the cochlea, where it opens into, through which the electrode for the cochlear implant goes inside till the apical turn, basically, where you can see the scala media, the scala tympani above, and the scala vestibuli, where the organ of Corti is present, and where the electrical impulses come from and transmitted to the cochlear nerve and so on to the brain. In cases of cochlear implant, the organ of Corti is gone. It is non-functional. So you put an electrode in the apical area so that you send a lot of electrical impulses inside, and that they can travel through the cochlear nerve, which I'll show you in some time, the cochlear nerve basically. So that's the cochlear basal turn. You keep on going above, then you can see the cochlea coiling up, forming the middle turn. This bone which you can see right here is basically the interscalar septum that divides the basal turn with the middle turn. And then in some time you can see the apical turn as well. Now what you can see over here is the glimpse of the internal auditory canal. So if I keep my the navigation over here, you can see on the coronal scan, you can see coming from the medial to the lateral aspect, this is basically the internal auditory canal, and you can see that faint bony projection right here. Follow my cursor on the coronal scan. You can see a faint bony cursor over here. That is basically nothing but the crista falciformis. That is the division of the IAC into superior half and the inferior half. So we all know there are 4 quadrants of the IAC: anterior superior, anterior inferior, posterior superior, and posterior inferior, hoisting all the different nerves, which I'll be showing you in detail after some time. Okay, so that is how it works. Now coming back to the cochlea here again, if I keep going above, so after knowing the basal, the middle, and the apical turn, what you can see over here, the cauliflower like structure, is basically nothing but the modulus of the cochlea. Okay, that's the modulus. That is basically the internal architecture of the cochlea. That's the modulus you can see right there, and that's the glimpse of the IAC coming into the picture right now. So if I keep on going above, you can see this is the actual modulus of the cochlea. You can see all the bony partition inside, and you can see the bone which is projecting medially on towards the cochlea, and then this is the glimpse of the internal acoustic canal, basically IAC. Now if I keep on going above, you can see the cochlea will disappear in some time, and this internal acoustic canal will form a more horizontal part and opens up into the middle cranial fossa. So basically this is middle cranial fossa and this is posterior cranial fossa. That's all the dura and that's the brain over here. So this is the internal acoustic canal which is in connection with the middle cranial fossa and the PCF basically. So coming back from below to above, now I'm going to concentrate on the cochlea and the cochlear aperture. So this was basically the bony architecture of the cochlea, the cochlear modulus, and this is basically, you can see a white bone over here. That's the white bone. That's the white bone, and you can see that this is basically the cochlear aperture. That is called as the cochlear aperture for the entry, for the passage of the cochlear nerve. Okay, so one of the contents of the IAC is the cochlear nerve, which is basically anterior inferior. Anterior superior is the facial nerve. Anterior inferior is the cochlear nerve. Posterior superior is the superior vestibular nerve. Posterior inferior is the inferior vestibular nerve, and then there's one more nerve which is a singular nerve which supplies the posterior most part of the posterior semicircular canal. Okay, so that is basically the architecture. Now I'm going to show you level wise. Now how can you identify from going below to above that this is cochlear nerve and this is facial nerve and this is superior vestibular nerve and this is inferior vestibular nerve and this is a singular nerve? Okay, I'll show you right now. So concentrate on the most basic below the inferior form of the cochlea. This is a basic basal turn of the cochlea. You're going above. Now you can see the basal turn kind of disappearing right now, and then you can see the more prominent middle. This is the interscalar septum, and this is the apical turn. So remember, the cochlea is in connection to the vestibule as well. Okay, so this was just the cochlea, right? Now as we're going above, this is a basal turn of cochlea, then the basal turn becoming less prominent, and then you can see something over here. This is basically the initiation of the vestibule. Okay, that's the vestibule into which all the semicircular canals open up. So if we keep on going above, now I'm going to keep my navigation on the vestibule, and on the coronal section you can see that was the cochlea below and this is a vestibule above, and this is a lateral semicircular canal and this is a superior semicircular canal, which I'll explain in the very last. So we have a connection between the cochlea and the vestibule, which is right here. The vestibule opens up into the oval window, and the cochlea, it opens up through the round window. So I'm going to show you where the round window is. So basically the round window is directed inferiorly like this, pointed like this inferiorly, and the oval window is opening in an oblique manner, which is over the footplate of the stapes area. I'll show you that in some time, but my main focus right now is the cochlear anatomy. That is the IAC basically. So if I just keep this over here for some time, a little below. Now this was the cochlea, the modulus, and that's the IAC. Now as we are going from inferior to superior, the first structure we will see is the inferior vestibular nerve and the cochlear nerve. Okay, and as we keep on going superior, then we're gonna see the facial nerve, because facial nerve is superior, cochlear nerve is inferior. So now on the axial scan, as we are going from inferior to superior, we are definitely gonna see the cochlear nerve anteriorly, inferiorly first. Okay, so let's find the cochlear nerve. So as I said, or as I told you already after some time back, now let me just zoom out this a little bit. So as I showed you some time back, this is the proper modulus of the cochlea, and this narrowing over here is the cochlear aperture. Now this is the IAC. Now let me show you the IAC. If I keep on going above, this is a proper IAC, and this is a level of facial nerve right there. But we are too superior right now because we are seeing the facial nerve here. That's the geniculate ganglia. So let me go a little below. I'm going a little inferior. Now I can see the cochlea over here, and that aperture is nothing but the passage of the cochlear nerve. Okay, that's the passage of the cochlear nerve. So this is the level of the cochlear nerve. That's the 8th cranial nerve. That's the cochlear nerve. And you can see a very faint fracture line over here, which is going in the vestibule. Let me see. Now this is still cochlea, right? This is still cochlea. So we can assume this is the cochlear nerve. That's the IAC glimpse, the very lateral part of the IAC. You can just focus on this faint crack-like structure which is going in the vestibule. Let me come back and show it to you again. See, this is the IAC. Now if I keep on going above, you can see that's the IAC. Now let me see the cochlea. Now that's the cochlea. It means that's the cochlear nerve. So the anterior inferior content is done. Now what about the posterior inferior content? Now as we know, this is more anterior and this is posterior. So anteriorly we have the cochlear nerve right there, and posteriorly we have this inferior vestibular nerve right there. This is a vestibule. That's the lateral semicircular canal coming in the picture right now. That's the vestibule. Okay, always remember, cochlea is somewhat anterior, vestibule is somewhat posterior in relation to each other. So as you can see, that is a faint nerve soft tissue shadow going right here. If I keep on going below, it means I'm going inferiorly. You can actually see that's the inferior vestibular nerve going to the vestibule to supply. What does the inferior vestibular nerve supply? It's the posterior semicircular canal. Okay, the superior vestibular nerve supplies the superior and the lateral semicircular canal. So this is basically the inferior vestibular nerve going at the level of the vestibule right there. So as we keep on going above, you can see that's the complete lateral semicircular canal, a signet ring shaped canal, but that later on I'll teach again. So as we keep on going above, you can see that the cochlea is disappearing right now, and now we are at a more superior level right now. So now what you can see is the IAC over here. That's the IAC, and that what you can see is the facial nerve. So the facial nerve comes here from the brain stem. It travels laterally. It enters the internal acoustic canal. So this is basically the cisternal part. So the place of the nerve where it takes its origin in the brain, that's the intracranial part, that is called as the cisternal segment. The cisternal segment is like this. It enters the IAC. It is called as the intracanalicular segment. And then at the very end or the lateral part of the canal, that's the IAC, this it forms a labyrinthine segment, and which exits the IAC basically laterally, and then forms a sharp turn right here. Let me go a little bit above. Yeah, there you can see that's the segment which is forming a sharp turn. That is basically the ganglion, the first geniculate ganglion of the facial nerve, and then it becomes the tympanic segment. You can see that's the tympanic segment going under the surface of the lateral semicircular canal. Now I'm going to show you that again and again, that how the facial nerve travels under the lateral semicircular canal. That's the lateral semicircular canal. That's the lateral canal right there, and that's the tympanic segment of the facial nerve. After the formation of the geniculate ganglion, it runs posteriorly. You can see it runs posteriorly below the level of the lateral semicircular canal, and you can see that's the facial nerve going below, and that's the facial nerve. Follow my mouse cursor. That's the facial nerve. That's the facial nerve. See my cross of the mouse. That's the facial nerve, and that's the vertical segment of the mastoid facial nerve, which eventually will exit through the stylomastoid foramen. So the pink dot which you can see right now is the facial nerve. That's the facial nerve. This is the facial nerve right now, and there you can see that's the stylomastoid foramen through which the facial nerve exits right there. You can see that's the facial nerve on the coronal segment. The soft tissue which you can see on my mouse, that is basically the facial nerve. And then you can see that's the styloid process, that's the mastoid tip, and that's the stylomastoid foramen, and there you can see the facial nerve exits. So this is how the facial nerve is, which I'll be showing you again after some time in detail. So this is how the anterior superior facial nerve is seen, the anterior inferior cochlear nerve is seen, the posterior superior vestibular nerve. Now I was supposed to show you the superior vestibular nerve, which I could not. I showed you the inferior vestibular nerve, which was very simple head-on finding. But then, okay, so what you have to do is just find, this is a geniculate ganglion right there. That's the geniculate ganglion. That's the labyrinthine segment right there. What you're going to do is just find at this level a faint crack-like structure going in the vestibule, which is not perceived on this scan, I guess. I don't know, I'm trying to see that. Now that's the labyrinthine segment of the facial nerve, that's for sure. That's the posterior semicircular canal. Let me just move this away. That's the posterior semicircular canal. That's the lateral canal on the axial scan. That's the lateral canal. You can see very clearly the signet ring appearance. That dot is the posterior semicircular canal, which I'll show you after some time. That's the disappearance of the cochlea. So that's the cochlea basically. That's the labyrinthine segment. I basically am not able to see. Yeah, there it is. There it is. I can actually see that. That's the labyrinthine segment of the facial nerve. You can see a very faint shadow here, right here. That is a very faint shadow, which is going in the vestibule right there. You can see that's the vestibule. That could be, that's the vestibule, right? So you can see a very faint shadow here right down. That's the exact thing. That's the superior vestibular nerve right there. So that's the geniculate ganglion taking a U-turn, forming the tympanic segment of facial nerve, and that exactly that soft tissue here is the superior vestibular nerve. Why vestibular nerve? Because this is a nerve which is going from the IAC part into the vestibule. That's the vestibule right there. So that's the superior vestibular nerve, that's for sure. So we've seen all the nerves of the IAC. Very difficult to visualize the singular nerve canal, which is in the posterior. So this is the posterior canal right there. We got to see posterior inferior, right? So this is the cochlea, this is the IAC. This is the posterior, this is the inferior vestibular nerve. Somewhere here should be a singular nerve branch, but not very visible here, I guess. Not very visible. Okay, so that was basically the IAC, the contents of the IAC, a rough estimate of the facial nerve, but I'll show you in much detail later on again. Now we move on to the semicircular canals. Now we did the cochlea in detail, right? We did the cochlea in detail. Now what I'm yet to talk about is the IP1, IP2 and the IP3, the Michel deformity and the Mondini's deformity, which I'll be talking about at the very end of this video because it is a bit advanced. So I'll take that in the very end of this video. So what I'm going to teach you right now, or what I'm going to show you in the very basics of now is the semicircular canals and the vestibule. Now for that to happen, now so I'm so sorry, let me show you the coronal image of the IAC before I do so. So if I put my navigation on the IAC over here, you can see the proper IAC and you can see a crista falciformis right there. This is a crista falciformis. So this becomes the if you're more, now let me come anteriorly, that's the cochlea. So that should be the cochlear nerve somewhere. So if I keep my navigation over here, you can see that is the vestibular, that's the superior vestibular nerve, and that's the superior vestibular nerve basically. And if I go on posteriorly, you can see that's the facial nerve. That's the facial nerve. So if I visualize the cochlea, that's the cochlear nerve right there. It should be the cochlear nerve right there. Right here should be the cochlear nerve. So if you can see, this was the cochlear nerve right there, and that's the inferior vestibular nerve right there. So if I focus on this, you can see that's the inferior vestibular nerve, and if I focus on this cochlea, that's the cochlear nerve which is going inside. Yep, see that is the cochlear nerve. That's the anterior inferior segment of the cochlear nerve exactly, and this was the facial nerve right there. So this is how you differentiate the cochlear and the facial nerve on the coronal and the axial scans. Now coming back on to the semicircular canals, for that I have to go very below. Now let me just focus. Yep. So coming back to the basic origin, that is the 3-point system, that is the mastoid, the styloid, and the ramus and the mandible basically. So if we keep on going above basically till you find the cochlea. So that was the cochlea right there. Let me just take this away. This is a cochlea, that's the basal turn of cochlea. Now keep on going above superiorly, you can see the cochlea and the vestibular system in connection. Now this is a vestibule. So we all know the vestibule opens up into the oval window. You can see over here is a faint shadow of the crus of the stapes. You can see the stapedius tendon as well. That's the long process of the incus, which will form the lentiform process, and then the head of stapes. So the stapedius muscle is basically attached to the neck of the stapes area. So you can see this is vestibule, and this is the oval window. You can see the bone between the two. So this is how you first identify the vestibule as its basic form. So once you see that this is the vestibule, I'm going to keep my navigation on the vestibule area. And once I keep the neuro navigation on that, on the coronal section, you can see that's the vestibule, and just below is the cochlear basal turn. So you can see something wing-like structure. Some people call that as a mermaid. Some people call that as alligator's mouth. Whatever it is, I just believe that this is the superior semicircular canal, the one which is going above, and the one which is going lateral is the lateral semicircular canal. So let me just zoom this for you. Yeah. So now this becomes more prominent. This is a vestibule over here. This is a vestibule, and that's the lateral, and that's the superior semicircular canal, and this is basically the entire vestibular area. So going further above on the axial scan right now, you can see that the vestibule is now turning into the lateral semicircular canal. Now it's very easy to know that this is lateral. Why? Because this is a signet ring shape on the axial section, and if I keep my navigation on the lateral, keep on encirculating it, you can see on the coronal section how it is forming a signet ring shape and coming back to its origin on the vestibule. So this is the entire lateral semicircular canal. So basically that's the lateral semicircular canal. Okay, after some time I'm going to show you the ampullated and the non-ampullated ends of each and every canal right there, but just now what I'm showing you right now is the basic anatomy. So pay attention. So this was the lateral canal. Now lateral canal is signet ring shape on the axial scan, and it just is one wing which is directing laterally on the coronal section, right? So this is that angel wings. You can see a mermaid tail. That's a mermaid tail, or the angel's wings, or you can say it's a alligator's mouth. The one which is going laterally is the lateral canal. The one which is going above is the superior canal. Okay. Now you do not see the posterior canal as of yet right now, but I gotta show you this. Okay, so what we saw over here was the lateral canal. This is a cochlea over here. That's the IC coming into the picture. Now pay attention. Now let me go to the very basic below inferior aspect for that. The moment you see the cochlea right there, see, let me take this away. The moment you see the cochlea, the basal turn of cochlea, the round window and the round window niche over here, pay very close attention as I'm going superior right now on the axial scan. You can see a faint black line appearing right here just at the base of the basal turn of the cochlea. That is basically nothing but the posterior semicircular canal. Okay, as I'm going above and above, you can see that it becomes more slender and more lengthier. That is basically the posterior semicircular canal. That's the first canal which you'll be seeing if you're going from the inferior to the superior aspect. And when you're coming from superior to inferior aspect, the first canal which you'll be seeing is the superior semicircular canal as a snake eye appearance, okay, which I'll show you again. So this is the posterior semicircular canal. These are the two ends of the posterior semicircular canal. You can see, keep your focus on this end, keep on going up, up. You can see my mouse cursor, you can see a black circle over here. That's still the posterior semicircular canal. Okay, keep on going up, keep on going up. Now you can see the lateral canal, the facial nerve tympanic segment, which is going running under the surface of the lateral canal. This is the cochlea, that's the IC coming into picture. And this black dot you can see over here is nothing but the posterior semicircular canal. If I keep my navigation on that, you can see on the coronal scan that this is the posterior semicircular canal. Now, this is a basic tip for all you guys out there. If you're seeing a coronal scan, which is right here, the most posterior canal which you'll be seeing is the posterior semicircular canal. Okay, so if you're seeing a coronal scan and if you're going very posteriorly, the only canal which you'll be seeing is the posterior canal, which you can see over here right now like this. That's the posterior canal. So on the axial scan, it just looks like a small black dot moving along. See, I'm keeping on going superiorly. You can still see the posterior semicircular canal. Then it's coming, and then it's coming, and then it's coming. And now you see what happens. This is a snake eye appearance. That is basically the superior semicircular canal. If I go on very superiorly, okay, this is a petrous apex region basically. So if I'm coming down, see, if someone is reading the scan from superior to inferior, now I'm going from the most superior to inferior right now. See, I'm going inferior. The first thing I see is a straight black line. That's a straight black line. This is basically the superior semicircular canal, the most superior prominence of the superior semicircular canal. Okay, as we keep on going below, it divides into two because it has two canals of the same dome shape, and as we go below, you can see it becoming into two halves. That is the anterior one and that is the posterior one. So what you can see, if I keep my navigation on that, you can see on the coronal scan, you can see this one, and on the coronal scan you can see this one. So this becomes the superior, that is the anterior basically, and this is the posterior end. Now keep a close attention. As I'm going down, I'm going down and down. You can see now something happens over here. Now this is something which I'll talk about later in the clinical significance. This is basically the subarcuate. Basically this is a canal called as the petromastoid canal. This is a petrous, this is a mastoid, this is a petromastoid canal which harbors the subarcuate artery and the subarcuate vein, but I'll talk about it later. So as we keep on going down, you can see the superior canal. This is the superior canal, but now we can see some shadow is extending from the posterior part of the superior canal. And now keep a close attention. As I'm coming down, you can see a canal extending and extending and extending, and then it's still extending, and then this is one more canal right there. Now what is this? This is the posterior semicircular canal. This was superior, but this is basically the posterior semicircular canal. Now basically, what is this? This is, now I'll keep going above again, I'll keep going up. So basically, this was the superior most dome of the superior canal, As we go down, it becomes anterior and posterior. Now this is basically the ampulated end, and this is basically the non-ampulated end. Okay, learn the difference. The one which is anterior, A for anterior, A for ampulated, and then this is the non-ampulated end of the superior semicircular canal. As we keep on going below, you can see the subarcuate artery and the vein in the petromastoid canal, which runs below the dome of the superior semicircular canal. And then as we go below, you can see an extension here. This is nothing but the posterior semicircular canal. Why? What is this exactly? Now this posterior semicircular canal also has an ampulated and a non-ampulated end. So this is a posterior semicircular canal whose non-ampulated end was opening with the non-ampulated end of the superior canal to form a crus commune, and that is the common opening of the posterior canal and the superior canal right there. Okay, this is very important to understand. Now if I keep my navigation on that union of the crus commune, you can see that is that crus commune over there. So if I'm going above, you can see that's the, you can see on the coronal scan the superior and the posterior coming in contact and forming the crus communes right there. That's the crus communes right there. And then as we keep on going below, now you can see the lateral semicircular canal coming into the picture right now, and this is the lateral. Now as we see, this was the ampulated end of the superior canal, this was the non-ampulated end, this was the ampulated end of the posterior, this is the crus communes over here. As we keep on going below, this is a lateral canal. Okay, so if you see the lateral canal on the coronal section, we have an ampulated end, which is this one, and a non-ampulated end, which is opening somewhere below. So they eventually open up into the vestibule. So, and you can see the posterior canal all the way down here. So this is a basic structure of the canal. So we saw the superior semicircular canal, we saw the lateral canal, we saw the posterior canal, we saw the crus communes, and both on the axial and the coronal scan. So if I keep my navigation on the posterior canal and I keep on going posteriorly, now see, this is the most posterior aspect and this is the most anterior aspect. So if you remember, I just sometime back spoke about the fact that on the coronal section, this is a coronal section, the most posterior canal will be the posterior semicircular canal. See, on the axial scan, when you go the most superiorly, you can see something like this. This is basically the superior canal. But on the coronal section, now see, if I keep my navigation on this, on the coronal scan, you can see like a dot over there. But if I keep coming down, it divides into two. You can see it divides into two and forms in connection with the posterior and forms the crus communes over here. But then if I go posteriorly below, that's the posterior semicircular canal right there, you can see. So that's the most posterior canal, and on the coronal section you can see this, this is a posterior semicircular canal right there. You can see, actually see on the axial at the same time, that's not the lateral but the posterior semicircular canal on the coronal scan. Very easily seen. Okay, so this is basic anatomy of all the lateral semicircular canals you can see over here. Now the most important aspect we have to see about the lateral semicircular canal in case of this patient. You can see this is a lateral canal and you can see the bone lying over the lateral canal. Now the first structure which you see once you open up the atrium during your mastoid surgeries, the bulge, the dome which you see is nothing but the lateral canal, right? It's the lateral canal. So if at all there is a bony dehiscence on the lateral canal wall, you can see that the bone is quite intact on this patient's CT scan, lateral canal. So if at all this bone is dehiscent and this canal is breached, the patient will definitely have something with giddiness, and that is called as lateral semicircular canal dehiscence. The same thing goes for superior semicircular canal dehiscence. Now that is much more seen. You can see the bone surrounding it. That is nowhere you can see any dehiscence, but that can be easily seen on the coronal scan. I can show you. Let me just focus. Yeah, there we go. So if I focus my navigation on the superior canal, you can see the bone is quite intact over here. The bone is quite intact, and if I keep on going below and keep my neuro navigation over here, you can see that's the canal over there, and that's quite an intact bone above there. If I keep it on the posterior non-ampullated end, you can still see the canal is quite intact, the bone is quite intact, and there is no sort of any dehiscence out there. So this is the clinical significance of the canals. Now what is left? Cochlea is done, the IAC is done, the vestibule is done, the canals are done. Okay. So now the structure which is left after having done the internal ear, the labyrinth entirely, the cochlea, the vestibule, the canals, the anatomy of the IAC, the contents, the nerves coming from the IAC, also having learned the basic anatomy, how to identify certain anatomic structures using certain landmarks. Now we come over to the section of the middle ear. Now what is the most important thing when your middle ear comes into picture is that the ossicles, right? Now I'm going to talk about the basic structure of anatomy of the ossicles, how to identify the malleus, the incus, the stapes, suprastructure, the footplate, the stapedius tendon, everything. So I'm going to show you some landmarks as to how you can, proceed stepwise. Because I've seen a lot of people, they just see randomly the CT scan and try to find the ossicles, and the moment they see the stapes suprastructure, they see, but it's not a proper way to look for the ossicles in a CT scan. So the basic most method is that you gotta go very inferiorly, like we always do. That's the mastoid tip. Okay, so as we keep on coming up, so on the coronal section, you can see that's the mastoid tip right there. So as we are coming up, you can see the external auditory canal coming in the picture right now, and then slowly you can see the bony and the cartilage EAC, and then later on you'll see the tympanic membrane. So once we see the tympanic membrane, we see the IAC, that's the ICA, sorry, the internal carotid artery and the jugular bulb. Now moving again superiorly, keeping the IA, that's the ICA in picture, you can see the promontory, now the basal turn of cochlea. The moment you see, you can see the moment you see the basal turn of cochlea, at the very same time, pretty much the same time, you can see the whitish structure right there. Now if we keep on going superiorly, it becomes more thin and slender and long. That is nothing but the handle of malleus. Okay, if I keep my navigation on this structure on the coronal scan, you will be able to see it much more clearly. Now let me just move this. Now this is basically the handle of malleus. You can see the head of malleus as well, and later on I'll tell you what this attachment is, right? Okay, keep a close attention, remember this. For now, keep a memory of it, that this is some structure which is attaching to the handle of malleus right there. You can see, I'll tell you in some time what that is. So for now, you can see that's the handle of malleus right there. That's the tympanic membrane right there. And I'm going to come back again on this picture to show you the scutum and the Prusac space again. But once we know the anatomy of the ossicles, I'll teach you that. So coming back on the axial scan, we saw the moment we see the basal turn of cochlea, we see something like this. That is nothing but the handle of malleus right there. You keep on going superiorly, you see one more structure which is whitish. Now that is basically the incus. Okay, that is the incus. Now if I try to go superiorly, you can see that's the incus. Then the lentiform process of the incus, that's basically the long process of the incus, which eventually forms the lentiform process. Now if I keep my navigation on this anatomy over here, you can actually see that this is basically the long process of the incus, and that you can see some kind of attachment right there. That is basically the stapes. Okay, that's the suprastructure, and that's the vestibule you can see over there. That's the cochlea over there. That's the oval window right there. So coming back to the axial scan, that's the basal turn. Let me just move this away. That's the basal turn of cochlea. That's the malleus. Then the second structure coming is the incus, the long process. Keep on going superiorly, you can see the lentiform process right there, and that is basically the head of stapes right there. Keep on going above, you can see the crust of the stapes, and then the footplate down there. Keep on going above, you can see these two dots. That's the malleus, that's the incus, and that's the body of the incus, and that's the short process of the incus right there, and that's the malleus right there. So keeping on going superiorly, you can see that this is now the epitympanum, this is basically the agitus, and this is basically the antrum. Okay, so this is the typical ice cream cone appearance of the ossicle right there. Now the ice cream is formed by the head of the malleus. The cone is formed by the body of the incus right here. That is a part of the body of the incus, and the short process of the incus. Now this short process of the incus is lodged within a bony canal that is called as the fossa incudis. Then this is the agitus, and then this is the antrum right there. So the clinical significance is that in cases of chronic mastocytitis, or you can say cholesteatoma, this entire thing is filled with the disease. You have to open up these are the periantral cells. Then you open up the periantral cells, you come from here, you dive into this area, and then slowly you achieve the patency from here, and then you can see the glimpse of the short process of the incus through that opening in the agitus. And then if the ossicles are diseased, you take them out and you refashion them, you reshape them, and you form a ossicular continuity eventually. So this is the basic anatomy. You keep on going superiorly, you can see the periantral air cells. Then this is the head of the malleus, the incus, and you can see the facial nerve. That's the lateral canal right there, and then eventually it disappears, right? Okay, so we keep on now we're gonna come back below again. Now there's one doubt I need to clarify. A lot of people have this doubt. Mostly I'll show that on the coronal section, because finding the ossicles is very easy on the axial, because the landmark which you have to remember if you're coming from below to above, the moment you see the basal turn of the cochlea, remember, the moment you see the basal turn of cochlea, you see the malleus. You keep on going above, you see incus. You keep on going above, you see the long process of the incus. You keep on going above, you see the stapes suprastructure, lentiform, and the stapedius tendon. Okay, that's the stapedius tendon right there. And then the epitympanum area will show, that's the facial nerve right there. That's the faint facial nerve right there. That's the ice cream cone appearance. The ice cream being formed by the malleus head, the cone being formed by the body, and the short process of the incus. That's the agitus that connects the attic with the antrum basically. That's the sigmoid sinus right there, and this is from where you enter and you prevent the entering to the sigmoid sinus accidentally. That's it about the basic ossicle structure. So coming back to the base, that's the more inferior part. Now I'm going to show you the anatomy, that doubt which everyone has got with the ossicle anatomy. I'll show you in the coronal section. Let me just focus on the ossicles right there. So let me just take my navigation and bring it over here. Somewhere should be here. Yes, so if you pay attention to this coronal scan right there, you can see something bilobed structure over here. Now if I focus on the screen, you will see a bilobed structure. You can see two circles attached in between, so this becomes a bilobed structure. Now if I come from the very now I'm going posteriorly right now. Now I'm coming anteriorly. If I'm coming very anterior, that's the TM joint right there. Now I'm going behind. you can start seeing the tympanic membrane right there. That's the epitympanum, that's the attic, that's the mesotympanum right there. If we keep on going behind, you can start seeing the first structure as the malleus over here. See, I'm coming back again anteriorly. Now I'm going behind. The first structure you see is in the epitympanum right there. That's the epitympanum. Now you're coming from the front to behind. So always remember, if you're coming from the front to behind, you are going to see this is something in the epitympanum, which is nothing but the head of the malleus. And then if you keep on going behind, you can see that's the malleus, and that's the lateral process of the malleus, which is attached to the tympanic membrane right there. If you keep on going behind, the lateral process is much more prominent, and then this is the head of the malleus. But now you can start seeing the bilobed structure over here. Now always remember that. Let me zoom this for you. A lot of people confuse themselves with the fact that this entire thing is in fact the head of the malleus, which is totally wrong. This structure, which you can see, which is somewhat lateral and posterior, is nothing but the incus right there. That's the incus, okay? That's the incus over here, and this is nothing but the malleus right here. So this is malleus and this is incus. Because it is a bilobed structure, you can actually clearly differentiate the thing that this entire thing is different and this entire thing is different right here. So keeping the same image intact right here, you can see that's the EAC, that's the scutum right there. Now clinical significance is that in cases of mastocytitis, not mastocytitis, but in cases of cholesteatoma, this is the first structure believed to be undergoing destruction in cases of cholesteatoma. Because of the constant retraction pockets in the pars flaccida, the epithelial dead cells get entrapped and lead eventually to the formation of the cholesteatoma. So that is basically a pars flaccida type of cholesteatoma. So the scutum becomes aborted, the scutum is absent. So whenever you see a CT scan of a patient with cholesteatoma having a pars flaccida type of cholesteatoma, you'll obviously see that a part of the scutum is obviously eroded. That means that the patient has cholesteatoma. Typical finding of that. This entire area where you can see that the ossicle is lodged is basically the epitympanum. This is the epitympanic area. Anything above is the epitympanum. This is basically the mesotympanum, and below is the hypotympanum. The space between the scutum and the ossicle over here is basically the Prusak's space. That's the Prusak's space. Going behind, you can start seeing that's the incus right now. You can see the incus right now. Now this structure entirely is the incus. You can see the body of the incus. That's the long process of the incus. And then you can see the stapes suprastructure right there. And you can see the oval window opening right there. So this is how you should be seeing the ossicles. Now what you can see, the faint shadow over here is the short process of the incus, which keeps on going posteriorly. So if I focus my navigation on this point particularly, you can clearly see that that point is basically the short process of the incus lodged in the fossa incursus. So this is a faint point, the most posterior aspect, and that is the short process of the incus. So if I keep my navigation here, you can see still the incus. Keep a look on the coronal. This is still the incus, still the short process. Now this is the body of the incus right now, and then this is still the incus, still the incus. This is still the incus, and now you can start seeing the handle of malleus, the head of the malleus right now in the picture, and then you can see the lateral process of the malleus. So the structure which I was talking about, the bilobed structure, is exactly this one. And this is the bilobe structure where you can see this is the incus and this is the malleus. See, this is the incus and this is the malleus. See my cursor. Now it's on the incus. You can see that's pink dot. See the pink dot over here now. See the pink dot On the coronal scan, the pink dot is saying that this is the incus, and on the axial it's still the incus. And you can see this is the incus, and now this is a malleus. So this is that bilobed structure which I was talking about. So a lot of people think that this entirely is the head of malleus, but not. This is incus and this is head of malleus. Always remember that difference. So the last thing which is left to teach is something which is called as the pyramidal eminence, the stapedius tendon, the facial nerve, and the sinus tympani. So let me show you how to find that. So go on the axial scan and go to the very inferior aspect, just like we always do. So this is a mastoid tip. We keep on going above till we find the ESC and the tympanic membrane. That's the membrane right there. And then later on we find the IAC, that's the ICA, internal carotid artery, and then the promontory, the round window. Then you can see the cochlea, the basal turn of cochlea. The moment we see the basal turn of cochlea, you see the malleus, right? Now keep on going superiorly. Keep on going superiorly till you find the incus appearing right there. Okay, now you can see something which is of a W shape, which is still very faint. You keep on going superiorly, till you find the stapes. Okay, once you see the stapes is there in their location, you can see, let me just zoom this for you again. Now the trick here is to directly go and find the stapes suprastructure. Okay, once you find the stapes suprastructure, you can see a very faint shadow over here. That's the pyramidal eminence. That is pyramidal eminence, and you can see the W shape right there. That's the W shape right there. Now what this W stands for? This peak is pyramidal eminence, for which there is the attachment of the stapedius muscle and the stapedius tendon, through which the nerve to stapedius also enters, which is branch of the facial nerve. Now there are three branches of the facial nerve in its vertical mastoid segment. The very first one is the nerve to stapedius. The second one is the nerve, that is the auricular nerve of the facial nerve, which gives off sensory supply to the posterior part of the auricle, somewhat like that. Third is the tympani nerve, the chora nerve. The chora tympani is the third branch of the facial nerve, going in the vertical segment facial. So this is a pyramidal eminence, the stapedius tendon, the muscle, and the suprastructure of the stapes. Then this depression over here, which is medial, that is sinus tympani basically. And this depression over here is nothing but the facial recess, and the soft tissue which you can see below the facial recess is the facial nerve. That's the facial nerve right there. So this is a W shape in the middle here. You have to be looking out for. Now the last and the most important thing is the facial nerve. Now to locate the facial nerve, you should know that the facial nerve arises from the brainstem area. Then it passes on. It has 5 segments. Always remember, the facial nerve has 5 segments. Now the very first segment, let me just zoom this out to have a bigger picture for you. Now this is very important because I'm going to compare the coronal and the axial to have a better understanding. So this is a petrous part, that's the clival part, you can see right there. Let me show you the IAC. Keeping on, see, this is a proper IAC. That's the brainstem area somewhere. The facial nerve arises from the brainstem region. It passes through the brain part, that is the cisternal part. Okay, that's the cisternal part. Then it enters the IAC. You can see that's the facial nerve right there, and not the cochlea. That's the facial nerve. So the cisternal part is the first part. Then the intracanalicular part is the second part. Then this is, you can see, this is a labyrinthine part. Just before the exit from the IAC, it forms a labyrinthine part. Then if I keep on going below, you can see a sharp turn over here. So it goes like this and then makes a sharp turn. So when it goes out, it takes a U-turn, and that U-turn is called as the genu, that consists of the geniculate ganglion, and then runs posteriorly. I'll show you posteriorly and downwards. Posteriorly and downwards. That's the facial nerve right there. It goes downwards below the surface of the lateral canal. I'm still going down. See, I'm going down. So the facial nerve travels from the genu posteriorly and backwards. Okay, posteriorly and downwards. The facial nerve travels posteriorly and downwards till this is a tympanic segment right there. You can see that's the ossicle right there in the epitympanum. That's the facial nerve tympanic segment right there. I'm going to follow it down. You can see this is the facial nerve right there. Now I'm going to keep on. See, I'm going to just take this away. This is a facial nerve, so I'm going to keep on going down. That's the pyramidal eminence which we just saw right there, and that was a facial nerve. Now this becomes the mastoid segment right now, because this is a mastoid. Now this is mastoid segment. Now you can see it's still there only. It's not coming down, it's there only. And we are coming down in the coronal section. It means it has become vertical right now. So now the facial nerve has become vertical. Eventually, once the stylomastoid foramen is achieved, you're going to see that nerve exiting outside. This is the facial nerve right there, and I'm going downwards. That's the carotid artery, that's the IGV, that's the facial nerve right there in the mastoid segment, vertical part. And then you can see it becoming very faint right now. Now that's the facial nerve. My mouse is showing the facial nerve, and then eventually let me have a focus on the, you can see over here, that's the facial nerve, the vertical segment of the facial nerve right there on the coronal scan. That's the mastoid tip, that's the styloid process, and that's the stylomastoid foramen right there. So I'm going down. You can see that's the facial nerve gone. The facial nerve is gone right now. That's the facial nerve right there. So this is how the facial nerve you can see on a CT scan and a cadaver dissection or a live surgery as well. So if at all there's now the clinical significance is that in case of accidents or in cases of trauma, in cases of tumor compressing on the facial nerve, or cholesteatoma causing erosion of the facial canal, the fallopian canal, the bony canal dehiscence is there, you can actually see each and every segment of the facial nerve on the CT scan. So if there's any longitudinal or transverse fracture in cases of temporal bone after accidents, you can actually see the facial nerve is involved or not. So that was a facial nerve course on the CT scan. Now what is left? I need to see what is left now. So I guess all the anatomy is done basically. The basic anatomy is done. The mastoid we have done, the internal ear, the ossicles, the middle ear, the ESC, the carotid artery, the IGV, the sigmoid sinus. Yes, there's one more point. I need to show the low-lying dura. I need to show you the tegmen tympani, the tegmen mastoidium as well. Let me show you on the coronal scan, because it is much more better appreciated in the coronal scan. So if I take my coronal scan, now I need to show you the difference between what is tegmen mastoidium and what is tegmen tympani. Okay, now I need to see the middle ear cavity first for that. So once I see the middle ear cavity, you can see that's the middle ear cavity right there. So anything, now this is basically the brain, that's the dura, that's the bone. Now if you're seeing, now let me just focus this navigation up here. So this is the tegmen plate. Now the tegmen plate, which is corresponding to the middle ear cavity, the roof of the epitympanum basically, that is nothing but the tegmen tympani. Okay, so that is tegmen tympani. Now what you can see over here is the tegmen tympani, which is in the middle ear epitympanum region. And if I expose the mastoid, so I need to see the mastoid antrum. Now that's the mastoid antrum right there. That's the mastoid antrum. So anything which is lining, that is a bony covering over here, which is separating the brain and from the mastoid. This is dura basically over here. So this is basically tegmen mastoidium. Okay, this is tegmen mastoidium or tegmen anteri basically. So if there is any defect in this post-operatively, you can have a prolapse inside, or you can have a meningoencephalocele. So basically that is the difference between tegmen tympani and tegmen mastoidium. So tegmen tympani is basically the roof of the middle ear. Tegmen mastoidium is the roof of the mastoid cavity basically. Now, when can you say that it is a low-lying dura, or you can say, now there's one more thing which you have to remember. If you go from posterior to anterior, okay, the tegmen plate comes medially and anteriorly. Always remember that. As you're coming from the posterior to the anterior, the tegmen plate is sloping from lateral to medial, and that too it keeps on coming medial and inferiorly. So it is coming anterior, medial and inferiorly. So if you're seeing the coronal section right there, see it's sloping right there. See, that's the most lateral part, that's the medial part. Now let me show you the tegmen tympani basically. For that I have to expose the middle ear cavity, and for me the middle ear should be somewhere here. That's the tympanic membrane, that's the cochlea, that's the vestibule. So this becomes the middle ear cavity. That is basically nothing but the tegmen tympani right there. That's the tegmen tympani right there. Okay, so if you can see now, if I'm going from the most posterior aspect, you can see on the axial scan this is the most posterior aspect, and if I'm going from the most posterior aspect to the anterior aspect, you can see that's the tegmen plate. From lateral to medial, it is coming, see it is coming anteriorly. From lateral to medial, it's coming anteriorly and inferiorly as well. So anterior, inferior and medially. Now if I'm going anterior, see I'm going anteriorly now. So it is coming anteriorly, medially and inferiorly. So this is a tegmen plate. You can see it's coming medially, anteriorly and inferiorly. Okay, and then it's gonna keep on coming down. It's gonna keep on coming down. You can see it's coming down. It has been coming down since we have traveled from the posterior to the anterior direction. You can see that it is coming down. I'm still going anteriorly. You can see it's still coming down. It still has come down, and it's going inferiorly, medially and anteriorly. Now you can see that's the mesotympanum, that's the epitympanum, and that's the tegmen tympani plate right there. If you breach this, you're gonna have a meningoencephalocele. So this is basically, now when do we call it as a low-lying dura? Now what you can see over here is the superior semicircular canal right there, and you can see some fracture line between. That is nothing but the petromastoid canal. This is a petromastoid canal which hosts the subarcuate artery and the subarcuate vein right there. Okay, so this is basically superior semicircular canal. This is the there we go, this is the subarcuate canal. So the moment you see the subarcuate canal, that's the petromastoid canal somewhere here, see you can see that's the level of dura right there. That's the level of dura right there. And if that level of dura is coming down here below or at the level of the petromastoid canal, it can be considered as a low-lying dura. So if I see the same thing on the coronal section, see this is a lateral semicircular canal. So for me, if this dura is coming down near the level of the lateral semicircular canal, it is definitely a low-lying dura. Okay, so this is a level of dura right there, the tegmen plate. If it is coming at the level of the lateral semicircular canal, that will be considered, or near the lateral semicircular canal, that will be considered as a low-lying dura. So whenever you are drilling your mastoid and going in the epitympanum, you really have to be very careful, because in that cases of low-lying tegment and low-lying dura, you won't be able to see your head of the malleus and the short process of the incus, because they will be obscured. But that comes on later on. Before that, you have to see that level of the dura inside. So any suspicion you can see on the CT scan, you can see this is a normal lying dura. You have enough space between the ossicles. See, if I'm exposing the epitympanum right there, that's the epitympanum, you can see. That's the epitympanic area, that's the ossicle right there. You can see there's ample amount of space between the superior most surface of the ossicle and the tegment plate. Okay, if this tegment plate is very close to the ossicle, or you can say at the level which is just near the lateral semicircular canal, it has to be considered as a low-lying dura. Okay, so you can study about that in cases of see, also here you can see the subarcuate eminence, which is roughly, now this is a superior semicircular canal. This is a superior semicircular canal. Basically, you can see the arcuate eminence, not very properly, but yeah, somewhat. So yeah, so basically these 2 points are there: the subarcuate eminence, that is the subarcuate petromastoid canal, and the lateral semicircular canal. So they can be considered as a low-lying dura. So I guess this is all the anatomy and the clinical significance which we have covered so far in this video. If you have any doubts, do let me know on my Instagram, Facebook page, or you can just put a comment below in the section, and I'll be happy to reply to all your doubts as usual. Thank you.